Hi, my name is Dr. Lori Spoozak, and I'd like to thank you for joining us for Case 7, Palliative Care and Shared Decision Making. I'm a gynecologic oncologist and palliative medicine provider at the University of Kansas Cancer Center, and I'd like to thank the organizers of the Evolution Conference for the opportunity to discuss this incredibly important topic. I'm joined today by Dr. Elizabeth Wulff-Burchfield, a medical oncologist and palliative medicine physician, and Dr. Jessica Hamilton, a psychologist who specializes in psycho-oncology. Thank you both for joining us today. I want to note symbolically that we're the last session of the day, and many physicians and patients regard palliative care and psychology as a last resort. The goals of our session are aimed at reframing the idea of when and where palliative medicine and psychology are most useful. When we think about palliative medicine historically, we have considered it in the context of end-of-life care or at the end of treatment. Interestingly, I think psychology as well has suffered from being a referral for patients as a last resort for severe psychiatric symptoms. What we hope to do today is dispel myths about palliative care and psychology for providers and patients, define primary palliative care versus specialty palliative care, and to understand the goals of the palliative care visit and the psychology visit, reframing healing and hope beyond the language of cure and remission. Before we start to talk about our case, it's important to have a framework for this discussion. Dr. Wulff-Burchfield, what is the contemporary definition of palliative care?
Thank you for the opportunity to share the modern definition of palliative care that we in the field use, which I think probably differs quite a bit from what people might envision themselves. So I think one of the best summaries really comes from the Center to Advanced Palliative Care, or CAPC. And I would say that the broadest definition is sort of specialty medical care for people who are going through a serious illness. But it also includes more specific components, including the idea that this medical care is often aimed at relief of stress or suffering from the symptoms caused by the serious illness. And this can range from oncologic to any number of non-cancer related serious illnesses. And the reason that this is undertaken is to promote a good quality of life for the patient as well as the people who love and support the patient. And palliative care is conducted by a team of physicians, advanced practice providers, nurses, social workers, chaplains, and several other specialties who all work together and with the patient, the clinicians who are managing the primary serious illness to provide another layer of support and promote wellness. And palliative care, finally, we always say is appropriate for any age and any stage, not limited to adults or children, to people who have curable or non-curable illnesses. And it can be and should be provided along with treatment of the illness itself.
Thank you so much for that definition. I think it's really important to differentiate right away the difference between palliative care and hospice. And as we heard from Dr. Wulff-Burchfield, both include an interdisciplinary team. Both are available to patients of all ages and any diagnosis, as long as it's a serious illness. But where they diverge is that hospice patients really have to have a prognosis of less than or equal to 6 months if the disease follows its usual course. Hospice usually happens at home versus palliative care, which mostly happens in hospitals, but a growing body of research supports its practice in the outpatient setting, where both myself and Dr. Wulff-Burchfield practice palliative care in the outpatient cancer center. And palliative care is billed like a regular physician service, whereas hospice is a benefit specifically under Medicare. Dr. Hamilton, Could you also share how you would define clinical psychiatry and the differences between that and psychology?
Absolutely. It's also one of those common discrepancies that people get confused about pretty frequently. Psychology at its core is the study of human behavior, and it has grown and expanded similar to medicine to include areas of specialty, including clinical psychology, which is looking at principles, methods, and procedures for understanding and predicting, hopefully alleviating emotional, biological, psychological, social, or behavioral discomfort. As the field of psychology grew, another area of specialty was really focused on health. And I like to point out that in those subdomains I just mentioned, this idea or concept of a biopsychosocial model really came to be for health psychology. And I believe that that's continued to be integrated into medicine, moving away from the biomedical model into more of a biopsychosocial model, as we understand how these psychological and social aspects become more important for us to address in health in general, and now even more specifically in oncologic care. Health psychology really encourages that integration of that biomedical information for health and wellness. And from that, psycho-oncology was developed. It is a more recent area of specialty, and it's really looking at the deep impact on patients' physical and mental well-being as they go through their treatment trajectory. We focus on emotional problems such as fear of progression, assistance with practical problems like the idea or concept of returning to work, childcare, social support concerns or areas of improvement like caregiving, how to communicate with family, children, improvement in general health like lifestyle factors like dietary concerns, physical health symptoms like pain and fatigue, and ultimately the optimization of treatment adherence and treatment decisions and existential factors. And I want to point out that these things really do strongly overlap with a lot of the core concepts and areas that Dr. Wulff-Burchfield and you have both just kind of covered, and those similarities between palliative care and psychology. You mentioned psychiatry, and I just want to briefly also mention that there is a difference between psychiatry and psychology. So I have my PhD or PsyD, so my training is slightly different, where I went through a different program where I wrote a dissertation and did a lot of education that was really focused on testing and medicine versus medicine, and psychotherapy versus psychopharmacology. So psychiatry goes through that traditional medicine path, and then they do their residency, which is usually 4 years, working with psychopharmacology. For psychologists, we usually do primarily therapy, and those sessions are usually 45 to 60 minutes typically, where psychiatry, you're still going to have that 15-minute more medical-based model of care. I also want to point out that while at our facility, we currently do not have any psychiatrist that works at the cancer center. We do have the ability to refer, but that there is a specialty in psychiatry for cancer patients. And I think that that's an area of potential growth here in the Midwest and moving forward.
Thank you so much, Dr. Hamilton. I can see so many overlaps between psychology and palliative medicine. I think that there are definitely huge benefits that are underutilized and need to be explored further. Now that we have our foundation laid out, let's introduce our patient, Nikki K. Nikki is a 51-year-old with recurrent metastatic triple-positive breast cancer. She underwent a pretty typical initial treatment in 2009. She developed a recurrence in 2017, and she was first referred to palliative care in January of 2018 for pain management. Dr. Wulff-Burchfield, do you think that this is an appropriate referral to palliative medicine?
Absolutely. I think this is certainly someone who can benefit from concurrent palliative care and ultimately help facilitate the oncology treatment plan by helping her live her best life and avoid toxicity.
Tell me a little bit about the differences between primary palliative care that I might provide in my GYN oncology hat versus specialty palliative care.
Absolutely. I think this is, palliative care as a whole is something that I would say any clinician who has ongoing longitudinal care of a patient is doing in some form or another. But we do differentiate between primary and specialty palliative care. In some ways, I think most people who do primary palliative care would never consider it as such. So primary palliative care includes the sort of core tenets about relieving suffering of all sorts that would be done by any number of clinicians with patients, that they follow for continuity. So this could be pain assessment and management, support for and medication management of depression, anxiety, and kind of mood disorders, as well as the, foundational discussions that people would have with their patients about the nature and stage of an illness, the expected, sort of big picture expected trajectory of an illness, as well as sometimes they're having discussions about medical treatment preferences, which could mean medical treatment preferences at the end of life, like code status, as we call it. Specialty palliative care just really builds on all of that. And I think in every instance, when we receive patients from our referring colleagues, we're taking what they started and adding to it, and certainly not replacing anything. We're always grateful for the work that people have put in to lead the patients to us. So that can mean managing complex pain, sometimes with, managing combination nociceptive versus neuropathic pain together with multiple layers of medicines and or interventions. Can include sort of more complicated or management of perhaps refractory mood disorders, as well as things like existential pain and suffering. We can also help with communication, which could be, between patients and their loved ones, patients and their clinicians, patients, loved ones, and the patient's medical team, as well as sometimes the patient's multiple medical teams, because as anyone who's had a serious illness knows, they end up with a longer list of doctors and providers than they ever wanted, and not everyone talks to each other in an optimal way at all times. We're all very busy. I think another way that palliative care has extra training is that we can help educate patients and families about medically inappropriate versus appropriate care, including if we believe that the patient is approaching a time point at which aggressive medical interventions can't offer benefit. So those are some of the ways that we add on what our other colleagues do.
Interestingly, Dr. Wulff-Burchfield, I think that some people might assume that as someone who's trained in both oncology and palliative medicine, we might not refer our own patients to palliative care doctors. But actually, I know that if my patients have reached that level where they require a specialty palliative care consult, I actually absolutely refer to another colleague, because most of the time we can't manage these types of issues in our typical oncology visit. And so I'm curious, what's your experience with that and what's your approach?
Well, I mean, we've both managed each other's oncology patients in our own respective palliative care clinics, actually. And what I would say is that, as you're saying, when patients have advancing illness, especially with complicated pain, physical or existential, spiritual, et cetera, their needs can amplify. And it's hard for us to really truly meet them within the 20-minute visits that were really allotted as oncology providers. And this isn't to say that the system is rigged against providing good patients care. It's just that because of the existence of palliative care, we don't have to block our oncology clinics to have really long visits in order to meet all of their needs, knowing that this is team science. We can refer to trusted people to hand the baton to. So my feeling about it is that sometimes I can manage, patients' pain and address their suffering and during the span of our visits and manage what their caregivers need. But again, if they have needs that are escalating for whatever reason, and at any time point in their illness, even if they're getting treatment with curative intent, then I am ready to flip the switch and add palliative care to their team in order to optimize their experience.
I 100% agree. And Dr. Hamilton, what do you think about the timing of psychosocial referrals? How could we be doing it better, and when are they appropriate?
Oh, I mean, research shows that the earlier the better. And I can speak to as a person who is in charge of the implementation of distress screening at our cancer center, that in looking at how and when these referrals are being placed, a lot of times referrals for psychosocial care are actually being placed near end of life. So within the last 6 months of somebody's life, referrals to psychology, social work, palliative care are occurring, which is, I think, exciting in some ways, but also sad in that we're not doing it sooner. I know myself, I would love for psychology to be incorporated very early on at the time of cancer diagnosis, frankly speaking, to help mitigate any of these, symptoms of anxiety, depression, communication issues, work-related issues, whatever it might be that patient may be experiencing on the upfront end. I know for palliative medicine, the same would be true, where the earlier you're incorporated in, even if they're not frequent appointments, just to introduce yourself and allow that patient and that family to understand what palliative care's role is, to become familiar with your face and you as a human, and to know that they have that support along the way. There's also a lot of other supportive care services that could be incorporated, such as social work, nutrition. I think a lot of times nutrition's incorporated pretty early on and then forgot about. But as patients are going through their cancer care, I frequently will refer back to our nutritionist at the cancer center because their needs change across their treatment trajectory. Spiritual care, another one that I feel like can be really beneficial is rehab oncology. That there is a really great place for that in our supportive care services, as well as pelvic floor therapy or occupational therapy. And Nikki, for example, I don't know if she did, but sexual health is something that can be very important for our gynecological or breast cancer patients. And pelvic floor therapy, I can't tell you how many of my female patients have benefited from pelvic floor therapy. And I think that that's something that we could be incorporating in as well into our team.
And I echo 100% about not being afraid of, and in fact, being enthusiastic for team medicine and team approaches to care. And the earlier, the better. I can't echo that enough. So I totally agree. Thank you so much for that. Let's turn to Nikki and ask her to demystify palliative care. I think a lot of people are afraid of palliative care, including other clinicians, because they don't actually know what happens at a palliative care visit. The same might be true for psychology visits. So let's ask Nikki, what is palliative care?
I think people, when I say, I've got an appointment with my palliative care doctor, they are alarmed because they think it's, does that mean things are really bad? People think it means, you're dying right away, and so it's confusing for people.
So I'd like us to explain this a little further. Dr. Wulff-Burchfield, can you speak about how palliative care explores multiple domains of care?
Yes, absolutely. So I think that our colleagues in oncology and many other specialties are being very intentional at managing or assessing and managing pain, because we know that's such an important part of overall well-being. And I think we in palliative care often sort of take that to another degree in order to try and really understand the global picture of wellness for a person, and try whenever possible to implement directed and validated tools to assess these different domains. So we're trying to we want to make sure patients' symptoms are assessed and managed properly, of course. We always want to try and understand how is their experience otherwise? How are they functioning in their home? How are their relationships going, and how is their support system? How are they using the resources in their community, and how are they functioning in their role in their community, whether as a working person or someone who's at home, for example, or as a neighbor? What's changing there for them? How are they reconciling their illness with their faith system if they have one? And also, how are they integrating information about the expected disease course and trying to create a mental picture for themselves about what their life expectancy could be and how we think their life is going to look throughout the disease trajectory. So we try really hard to do that globally for every patient.
So if we think about a typical tool you use, like at your palliative care visit, what are some of them that you use? Is this one of the tools that you use, the Edmonton Symptom Assessment Scale?
We do. So sometimes these fall into the broader category of patient-reported outcome measures, which is essentially anything. A patient-reported outcome measure is anything that the patient completes based on their own beliefs and experiences and symptoms, et cetera. So we do use the Edmonton Symptom Assessment Scale at the University of Kansas Palliative Care Clinic at the Cancer Center, the ESAS. And we use this in order to try and create at every visit a few things. Number one, a template for what the focus of the visit should be or what it could be. We don't draw labs or do scans in palliative care at KU, although I think that differs by practice and institution, et cetera. But we use this as our way to kind of assess the person and see what's underneath the surface. We also follow it longitudinally so that we can get a sense about how things have changed and how that relates back to the nature, kind of the status of their illness. And the other thing is, I think that it promotes introspection for the patient, because a lot of times they are used to answering the same questions at a lot of visits, and some of them aren't asking about, for example, how is the overall quality of life, and what of these factors are contributing to it or detracting from it?
You know, what's interesting is that there are a number of studies that also reveal that if you don't ask, people don't tell you. And symptoms have revealed the same thing, right? So that a lot of our patients don't report these things unless we directly ask them. The same is true for sexual health, as Dr. Hamilton brought up. People are shy to share, and or it doesn't occur to them that these things might be symptoms. And Dr. Hamilton, can you speak a little bit about screening tools for depression or other psychological conditions? And are they similar for underreporting?
Yeah, actually, absolutely. So overall, any self-report measure we know is going to be more honestly completed if the individual is completing it on paper, pencil, or tablet versus oral communication. So when somebody's asked verbally, if like for example, on the ESAS, it says not drowsy or want possible drowsiness.
The worst possible drowsiness.
Yes. So on the scale of 0 to 10, where do you fall? If you ask a patient that verbally, they're going to probably score that lower than their actual experience is. Also, if you're doing that as a physician, or if you're at a medical oncology appointment, anything that could be viewed as a negative, patients will generally underreport. And that is unfortunate, but it comes from a lot of fear that because of depression, that could interfere with their ability to get their next chemotherapy treatment, or that the doctor's going to say, oh, well, we don't want to burden you too much, let's change treatment courses, or that they're not going to get the best care. If they're anxious, they don't want to be bothersome to their physician. So they really just want that medical oncologist to be able to provide them with optimal care, and will underreport or not communicate some of their needs from time to time. So again, palliative care is an awesome opportunity for them to be able to freely communicate on the ESAS or other measures that are being asked of them. In psychology, frequently what we're doing right now is looking at the PHQ-9 or the GAD-7. There's a lot of CMS guidelines associated with using those two scales, particularly, and for trying to make sure that we have continuity across a health system, we're continuing to use the PHQ-9 and the GAD-7. So the PHQ-9 is a 9-question depression inventory, and the GAD-7 is a 7-item anxiety inventory. In the field of cancer, there's several other questionnaires that are frequently used, such as the PROMISE, which can be a comprehensive evaluation looking at socialization, physical health, fatigue, difficulty sleeping, cognitive functioning, and trying to get more of a comprehensive evaluation of how the patient's really coping overall, not just anxiety and depression. There's also symptom checklists where we're looking at unmet needs. And then the other thing specific to cancer is the distress screening, as I'm sure the majority of you guys are aware of. So in 2015, the COCs put out the mandate that we need to be assessing distress at least one time during a patient's cancer care trajectory. Using the distress thermometer, which is that 0 to 10, analog scale, anything that is a 4 or higher is actually considered clinically significant. And I think that's important for us all to know, because a 4 is relatively low. And if you think about that underreporting that we were just talking about, a 4, if we took it outside of cancer care, may be more of like a 6 or a 7. And so at that time where you're starting to see a 4 on that distress scale, or a 4 possibly on the ESAS, that's really noteworthy for us, that we want to make sure that we're doing some type of intervention to help alleviate some of the distress that might be going on. The checklist or the unmet needs can actually help us identify where those concerns are, or where the distress might be coming from.
Thank you so much. And what you said, I want to echo. It actually is exactly true that for the ESAS score, it's clinically significant if it's 4 or greater. So we might think someone is doing fine, but even at that number 4 score, that actually is extremely meaningful to start paying attention and working a little harder. The other thing I want to echo that I think is really critical in talking about sort of the conflict of interest of providing all of this other global care and doing the cancer-directed care is that patients don't tell you, because you're the gatekeeper for treatment if you're the oncologist. And so it's so critical at all parts of their treatment journey to really think about having another group of team members on board to help assess all of those other domains of care outside of their cancer-directed care. I think another big thing that we always think about at our palliative care visits is the palliative performance skill score, and just prognostication in general. Dr. Wulff-Burchfield, this is frequently not taught in oncology beyond the sort of ECOG scale. And most of the time people sort of assume they know how to do it, but maybe aren't really given an education in how to do it and how to explore that. Can you discuss sort of this scale that we're looking at and this tool and how this helps with prognostication for our patients?
Absolutely. So the Palliative Performance Scale, or PPS, it's rooted in really robust research in order to help essentially map where a patient stands with regard to their ability to ambulate and perform self-care tasks, as well as eat and drink, and their level of consciousness, and sort of can relate that to a predicted life expectancy or prognosis. And the reason this is so important is because no matter how much clinicians try, unfortunately, research shows that we're just not good at prognostication. And actually, in oncology, it shows that the longer that we've known a given patient, the worse we are at it. And I really just think that's due to human nature and our all that we hope from, all the hope we have in our hearts for patients to live as long as possible if that's what they are wanting. So by using a tool like this, that's really based in research and has been validated, we can use the data that we get from the patient about how they're functioning and get some more concrete numbers. And we use this to help inform our patients and make sure that they're choosing medical care that is a good match for their goals in light of how long we think they may live.
Thank you so much. So let's return to our case, Nikki, and her palliative care visit, and what we learn when we start exploring all these other domains of care outside of her cancer-directed treatment. So she has an ESAS score for pain of 8 out of 10. It's in her spine and her hip. We all learn probably in medical school the PQRST, of pain. Some things that we neglect are thinking about how that pain medication or that pain intervention actually makes their pain scores behave. In palliative care, we explore where their pain score goes to when they take an intervention. We also explore what their goal is for pain management. Some people have unrealistic goals of living without pain. And in fact, we need to reorient ourselves to where their functional score for pain might be. And for example, with Nikki, her functional level would be at a 2 or a 3, not a 0. So 2 or 3 means that she can enjoy her family and life at that level. Her pain meds, they last 4 to 5 hours. We learn that she's married and she has 3 kids. She does admin work for a nonprofit and would love to continue working if her symptoms can be controlled. And she has a strong faith system. She's Christian. She participates in a Bible study group, and prayer is really important for her exploring her cancer and managing her pain and symptoms. Dr. Wulff-Burchfield, I think a functional goal for pain is something that most physicians aren't familiar with. And can you say more about that when you're assessing pain or any symptoms, how you sort of ground those things?
Absolutely. The way that we often think about it is, where does your symptom, be it pain or otherwise, where does that need to be in order for you to live a life with meaning? For most of our patients, they learn, unfortunately, pain is common among the patients that we work with. And so they often learn that getting pain completely controlled is not going to be achievable, and at least not with the levels of medicines that will allow them to be awake, alert, and safe. And so a lot of what we're trying to do is see, okay, where is your pain these days? And then with it at that level, what does that allow you to do? What does that prevent you from doing? And what do we where would it need to be in order for you to do the essentials, as well as anything else that you would like to do that's maybe non-essential?
And Dr. Hamilton, in palliative care and psychology, there's significant attention to these domains of care outside of physical symptoms. How do these curiosities help introduce explorations about meaning and value? And how do these explorations inform a patient's experience of quality of life?
From a therapy perspective, meaning-centered therapy and ACT, which is acceptance commitment therapy, really are commonly used in exploring meaning, values, and this idea of hope, and recognizing that all of these things can actually be pretty malleable throughout the course of their cancer trajectory. A patient's understanding of that conflict between quality of life and quantity of life is something that these therapies really allow us to discuss more specifically, and recognizing that ambivalence is normal and healthy, and using their values to kind of help them guide their way through when quantity of life or quality of life is more important, and how so. I think it also helps them explore how they want to live, most importantly, through cancer, whether that be ending in survivorship or in death. Identifying how to live, I think, is the biggest hope I have as a provider, is helping them identify those goals, and then being able to set those goals using these therapeutic approaches, where they can identify the activities they want to engage in, the people they want to spend time with, and what they want to do with that time, and speak safely about it. I think a lot of times when people start thinking about moving in or transitioning into what is quality of life for themselves and making some of the difficult decisions near end of life, this idea of dignity and honor come into play. And at the same time, with ambivalence, the idea of shame or failure, and being able to talk about how identifying that dying with dignity and allowing them to say, I don't want any more treatment because my quality of life is important, and then how to communicate that feeling of honor to their friends, their family, their treatment team, and it not being something where they're ashamed because they've done everything the right way and in line with who they are and their values. And their hope then moves towards having good quality time with whatever it is that they want to do.
Thank you so much. So I think what we're gleaning from this is that a palliative care visit is much more than that initial concept that Nikki shared with us, where it's like talking about death, dying, and the end of treatment. That palliative care and psycho-oncology explore so much more. Let's hear Nikki's impression of her palliative care treatment after the ball got rolling.
I've been so surprised to learn that it's just more where we talk and you help me with ways to live well with cancer and ways to move through the journey and, you know, plan for the future, whether I'm here or not here, you know.
I promise I didn't pay Nikki to say that. Dr. Wulff-Burchfield, something important that Nikki highlights is finding ways to live well. And this is a worksheet that I personally use at some of my visits. Actually, it was made by a patient and their family based on all of the things that we discuss at our visits. Can you discuss your strategies for helping a patient to live well with cancer? How do you make goals, or how do you help them set goals with palliative medicine, but then also in your oncology practice? How do you make treatment recommendations?
Well, I mean, our ability to help patients distill this down and then create an action plan really just depends on whether we have had the opportunity to get to know them and understand what makes them tick, what drives them. And so, but once we've done that, once we've had the opportunity to get to know people, a lot of times we're talking about, you know, what activities give them joy, what activities have meaning for them and or their loved ones, and then trying to find ways that we can package out some of those opportunities throughout their daily life, or, you know, it depends on what they're trying to do, but sometimes it's on a less frequent interval if it's with family who lives remotely, for example. But just trying to find actions that won't be too taxing for them, but that still get at the heart of what they want to do. For example, if what they really love is to play softball and they also really like to be there, have the fellowship with their teammates, then it may not be feasible they may not have the energy to spare to really be running the bases, or it may not be safe at certain points. But if they can rest up, take time out to go attend a game, sit on in the dugout with their friends, cheer them on, and then it can be a way that they can still experience some of the pure joy of that activity without having to expend too much energy and kind of go into deficit spending, as we say, with their energy budget. So we just try to be practical about it. I think Dr. Spoozak and I both really try to do that in both our practices.
And Dr. Hamilton, how can psychology assist with patients who struggle identifying goals?
Yeah, I mean, I think that this is something that we typically do, regardless of it being psycho-oncology or just traditional mental health care, is identifying what goals of therapy are going to be, which therefore then becomes the identifying patient's goals, and exploring ambivalence and things that they are really wanting to focus on and areas that are bothersome. When looking at ACT therapy, there's this idea of making toward moves and away moves. So toward moves are these ideas that are in line with who they are as a person and their values and the things that they want to accomplish, where away moves are things that are against those values, not intentionally though, right? Like things that pop up are fear of progression, or continuing to smoke during their treatment isn't necessarily in line with who they are and what they want to do, but it's the coping strategy that they've had for 40 years. So it's distressing to them that they don't want to continue to do that. And therefore, one of their goals might be to discontinue smoking. So it allows us to identify healthy goals by looking at the areas of distress in line with their values. Sometimes I actually make people draw pies of what their values are and where there's differences or discrepancies in what they ideally would like to be living versus where they are today. And becoming more familiar with adjusting to what their life can be and how to live within the scope of what their body's allowing them to be. It is part of that goal setting process.
Thank you so much. I think I need to draw a pie. based on everything that you just said. In fact, I feel that way a lot in my palliative care visits about reflecting on my own behaviors. After following with palliative care for many months, Nikki has a progression. Dr. Wulff-Burchfield, how do you approach visits for progression in your oncology practice versus your palliative care practice? Because people are really stressed out about this stuff.
Absolutely. You know, it's interesting. I would like to think that they look really similar, but they really don't. And part of that is because of what patients are expecting and what they want out of an oncology visit. You know, while I think I always want to reflect with patients about what the news of their growing or spreading cancer means to them, you know, how they're interpreting that. And you know, a lot of times their questions are, okay, well, we'll get to that, but like, what's the next treatment? And so a lot of oncology visits are very focused on logistics. So what treatments are available? Which treatments have the highest likelihood of controlling the cancer for a time if their cancer has progressed? And understanding what the risks and benefits are of the existing available treatments, and sometimes, you know, focusing on standard treatments versus clinical trials. Those are very pragmatic discussions a lot of times. In palliative care, I'm unburdened from those logistics. We get to just really sit down and have a human moment and ask, what did it mean to you when you heard that? Were you expecting it? You know, what does it make you think about your future? How is your family dealing with it? You know, and all of those really human aspects that, of course, you know, we as oncologists want to care for, but patients are looking for some very concrete information in their onc visits usually. And in palliative care, we get to just debrief, unpack, and prepare.
Right. And, you know, it's not just at the time of progression. Many of our patients suffer an exacerbation of symptoms during progression, but they also suffer tremendously around surveillance imaging. These are some of the apps and a tool card that I might use in my palliative care practice that help manage SCANXIETY and coping with cancer. Dr. Hamilton, what are your tips and tricks? How do you speak to patients to help them manage anxiety about scans and the concept of living between scans?
Yeah, this is something that a lot of people do struggle with, but in varying degrees. And then sometimes this can be something that's debilitating for a patient for months versus a lot of anxiety for 24 to 48 hours. So I love your card, your coping card here. Mindfulness approaches can be extremely beneficial. There's lots of different apps. You mentioned the Hope Box. Calm is another really good one that I've recommended to patients as well. The other thing that we do are cognitive behavioral therapy strategies, or very specific strategies. I call it the what if game, right? Because most of the time they're waiting for that what if negative, and learning how to challenge and recognize that there's a what if positive too, that's just as likely, if not more so, frankly, right? And then using their rational minds to identify and challenge some of those negative thoughts without judgment, because the thought is something that they don't get to control. I also use affirmation statements, which are similar to those coping cards. For people who end up having symptoms of panic, which can happen, I will usually do something called interoceptive therapy, which is letting people learn that just because they're anxious, it doesn't mean that there's an alarm going off, that is a false alarm in their body, and that while it's uncomfortable, it's not going to hurt them. And learning how to actually control those physical symptoms of panic can be empowering. It's not always fun, but it is very, very useful, and it can be a great tool for people who are having really severe scan anxiety. Setting up distractions and positive reinforcement, setting goals and communicating and enjoying other people during those times can also be very helpful. And ultimately, medications can be assistive as well. And there's nothing wrong with using a medication to assist, as long as it's not something where we're talking about that 3-month interval and it's something that is not helpful at that point. If it's something for the day of, I'm like, yes, please, it's okay. But I think that is obviously up to the medical providers, but I would not be opposed. If I was the person who was going to get a scan, I would probably want something to help me as well. Watchful waiting, though, is very difficult for patients. And I use similar approaches with both the scan anxiety as well as the watchful waiting.
Yeah, so it sounds like the message is that there are a number of tools that we can use to help our patients cope with their cancers, whether or not that cancer is controlled, whether or not there is no evidence of cancer in their body, whether or not their cancer is progressing, that there are so many tools available to us, and including palliative care and psychology, but also that all of these tools are freely available online, so that as an oncologist, you can reach out and acquire any of these tools to pass on to your patients right now. You know, I think overall, coming back to facing a severe life-threatening illness, we really have to shift our focus from only dwelling on whether or not we can get to cure and remission to coping with cancer and living well. So we can help our patients navigate uncertain prognosis, especially in this time with targeted therapy, immunotherapy, maintenance therapy, you name it, we've got it. Prognosis is more uncertain than ever. And in this graphic model here, we see how that shift occurs when our patients, over time, working with providers like palliative care or psychology, are able to embrace a dual framework where they're able to focus on living well and acknowledge dying. And we're going to close listening to how working with palliative care has affected Nikki as we listen to this last interview.
With palliative care and everything I've learned, that I feel just, like I have the tools to be able to manage what's going to happen in the future. I feel hopeful that it's going to be good, but I know there'll be ups and downs, and I know there's going to be scans that probably aren't going to be good in the future. But yeah, I feel real hopeful that I'll be able to just get through it.
So what I hope you hear in this excerpt is all of the work from these visits that we're doing with a patient like Nikki, with all of our patients, to help them get to this place. Nikki is exceptional, maybe, in her willingness to engage in this work, but what do you think, Dr. Wulff-Burchfield? Is she exceptional, or are most patients willing to get there?
Well, I think a lot of times, or at least historically, there's been this notion that we shouldn't talk about scary things, including dying, because it takes away hope. But in a way that's sort of, arrogant or hubristic for us as clinicians to think that we would plant the idea of death in their minds. The thing is, patients are already living with those thoughts and those questions, and us giving them a safe and space and time to talk about it is, I think, very empowering for patients, reassuring, and also reinforces non-abandonment. And the other thing I found is that a lot of times patients want to be having these discussions with family, but sometimes family members or loved ones feel like they need to be the cheerleader and prevent any negative thought from entering the patient's mind, whereas that's really not true to the average person's experience. They're having those thoughts and questions. So also us normalizing creating the space, normalizing some of these discussions can also promote better communication and more closeness with their families and allow patients to navigate those better as well. So I think most people don't hope for avoidance. They hope for safety and comfort, and we can offer that to them, excuse me.
We understood and also agree. And Dr. Hamilton, what do you think? Do these conversations, does this whole way that we approach care, does it take away hope? What do you think?
Oh, I think it aspires hope in a lot of different ways. It opens the door to conversations about how hope is malleable and it can change over time. And it doesn't have to be this notion that everything is perfect all the time and that we have to hope for an idealistic ending, that hope can be something very beautiful. I came into cancer care not truly I just got thrown in my first day of internship to cancer. I had no idea what I was doing. And at the end of the day, I had a conversation with my supervisor, which at the end of the day is when I decided this is what I knew I wanted to do, of identifying that we can help an individual identify how they want to live their life and the hope that they can have during that time. And it can be so beautiful. Everybody celebrates births, and not that we need to celebrate death, but we can definitely celebrate the life that they're living in the process, and the hope that they carry. And it can be equally as beautiful, in my opinion.
I totally agree. That echoes with me. I think about reframing miracles. I know a lot of our patients are always asking for miracles. And I also share with them that I am open to miracles, and also challenge them to explode their mind about what miracles might look like at different times in their illness. Maybe a miracle is enjoying a cup of coffee. Maybe a miracle is seeing their grandkid one last time. Is it only cure from their cancer? And so I think that all of the work that we're doing is really helping people reimagine the attachment to what healing is defined as, what hope is defined as, what miracles are defined as. And we're really helping them cope with a totally uncertain future, as we're all living and we've all grown more accustomed to in the time of COVID. Our futures are unknown. And I think we do a really good job of helping people come to terms with that, figure it out, and then move forward and live really well. So let's close on that. The work of palliative care and psycho-oncology has expanded to accommodate a growing population of patients who are living longer with complex illness, and will continue to work together to ensure that they maintain a high quality of life throughout that journey. Thank you so much, Dr. Wulff-Burchfield, and thank you so much, Dr. Hamilton. I tremendously enjoyed our conversation today, but also absolutely value you as colleagues. So thank you so much.